Chapman. And Dr. Chapman is an associate professor in geriatrics. Her topic is very important to us because of the increasing aging of our population of patients and the importance of frailty in the elderly, both recognized and unrecognized, which is a really important part of success or failure with surgery. So understanding that and treating it properly is the key, not necessarily avoiding elderly patients, but rather appropriate treatment of that. So we're very happy to have you here, Dr. Chapman. I think this is great importance to us. Thank you.
Great. Thank you guys so much for inviting me. It's great to be here. As the slide says, I don't have any disclosures. Geriatricians aren't big targets for pharma or anything else. We usually do prescribe, so they don't like us. So I wanted to start with something that I think about a lot. And funny enough, my colleague, Dr. Eastman, who spoke this past May, I believe, talked about Keith Richards as well. But you guys might remember that in, I think, 2006, he fell out of a tree and then several days later presented with a headache. And it turned out that he had a very large subdural hematoma that needed to be emergently evacuated. And he did great. So within 6 weeks after the drainage, he was back touring with the Rolling Stones and doing what he had always done before. And this kind of blows my mind because he doesn't on the surface seem like this bastion of like healthy living and healthy aging. And so I keep thinking to myself, like, why did he do so well? And I think the answer is that although he looks the way he does, he's not frail. And it turns out that frailty really is a major problem for people who have any kind of medical issue, but particularly in the neurosurgical setting. So today we'll talk about frailty and specifically how it impacts neurosurgical patients and the things we can do to mitigate some of the risks. So the title is Frailty in Older Adults, Identifying and Managing Hidden Vulnerability. And so the objectives for the next 45 minutes or so are that you'll be able to define frailty and talk about some of the diagnostic criteria to identify it. The tricky thing with frailty, just as a spoiler alert here, is that we don't necessarily have agreed upon criteria. And so it's not as though there is one gold standard for making the diagnosis, but there are certainly common themes that we'll talk about. The next objective is that you'll be able to summarize the impact of frailty outcomes in neurosurgical patients. This is apparently a very hot topic. In the past few years, there's been a ton of papers published. So all the cool kids are learning about frailty. And then finally, we'll list some practical ways to mitigate the risks associated with frailty. So getting started here, we will first cover some background on frailty. We'll talk about frailty specifically in the neurosurgical patient and then mitigating the effects, but we'll start here with the background. And so frailty, in my mind, the best analogy I can think of is like living paycheck to paycheck. So frailty is this state of reduced physiologic reserve that makes a person more vulnerable to insults. And if you think about a person who is living paycheck to paycheck, they might look okay on the surface. They're getting by, they have what they need, all their basic needs are met. But if something bad happens, everything goes awry. So an example might be someone who, is just making enough to cover their expenses, and then something bad happens, like their car breaks down and they can't afford the repairs. And because they can't afford the repairs, they can't get to work. And because they can't get to work, they lose their job, and then they lose housing. And in older adults and anyone who's frail, essentially they're meeting their day-to-day needs with what they've got just barely. And so if you throw anything that kind of upsets that delicate balance in their way, they're going to fall apart and not do well. And so that's sort of the general concept of frailty. But defining something like that is difficult because it is sort of a general kind of nebulous idea and can mean a lot of different things depending on the person. And so thinking back to Keith Richards, and again, I don't know his personal medical history, so I'm just making it up here. But I don't believe Keith Richards, despite how he looks here with his like cigarette and wiry frame, is frail. But if we compare him to someone who maybe based on our kind of traditional H&P looks very similar, there are probably some underlying differences. So we're going to compare Keith and an imaginary gentleman named Kevin. So they're both coming in with subdural. They both fell and developed headaches and then eventually presented to the ED where the CT head showed the subdural hematoma. And I realize that's misspelled there, SHD. Past medical history, the same. So COPD, hypertension, some coronary artery disease, remote polysubstance abuse. We know that's true for Mr. Richards. Family history, very similar between both of them. They both could be current half-pack per day smokers with a pretty sizable smoking pack year history. They might be moderate drinkers, married, living with a spouse. They might be the same size, 5'5" and 160 pounds. You can actually Google like how tall and how much do celebrities weigh. I found that out preparing for this. And it looks like Keith is 5'9" and 160 pounds roughly. And they both might be independent in activities of daily living. So they're both able to manage things like going grocery shopping. I doubt that he actually does his own shopping, but we can pretend that he would if he had the time. And they're both able to do things like bathe and dress themselves, et cetera. But maybe there's something under the surface that we're not seeing with this kind of typical H&P. So maybe Mr. Kevin here fell not because he was falling out of a tree while traveling the world, but tripped over the edge of a rug, which is a definitely more low trauma situation, right? And maybe his past medical history includes some new memory loss that no one's diagnosed yet because it's generally underdiagnosed in the population. And maybe he's 160 pounds, but that's because he lost 18 pounds unintentionally in the past few years. And when it comes to functional history, maybe he is technically independent, but he's giving up some of the heavier chores that don't factor into IADLs. And versus Mr. Richards here, who is performing in 3-hour shows on tour. When you look at it this way, there's certainly a bigger difference between these two, and that might explain why one would do better than the other when it comes to a major insult like a subdural. And when it comes to frailty definitions, one of the first, and one that is based on an understanding that frailty itself is underpinned by these physiologic processes, was Linda Fried, who developed something called the frailty phenotype. And it has 5 elements. So the first one is unintentional weight loss. And then next comes weakness, exhaustion, slowness, and low activity. And you can imagine how these could all be related, right? So you lose some weight, and with that weight loss, you lose some muscle mass. And when you lose that muscle mass, you become weaker. When you're weaker, you get exhausted more easily doing things that you otherwise would be able to do. And when you are more easily exhausted, you move more slowly. And when you move more slowly, you don't do as much. And so it all is very much a series and very intertwined. If you have 2 out of 3 of these phenotype elements, you're considered pre-frail, so at risk for overt frailty. And then if you have 3 or more, you're considered frail, and the more you have, the worse off you are. So this is one way of thinking about frailty and one of the first kind of definitions. But as you can imagine, this isn't like an objective thing that you can kind of like check off a list easily and diagnose. So other people have tried to come up with other measures for frailty. And these are just a few of them. There are truly tons. The frailty index is fairly common for research. So this is a list of 30 to 40 possible deficits that include things like certain chronic diseases, some health attitudes, functional status, symptoms or signs, and the number you have of these over the total number possible is interpreted as a frailty score, and there are different cutoffs depending on how many potential elements you include in the index. There's also the Edmonton Frail Scale, which has 9 domains, and there's scores assigned for each, and include things like cognition, health status, some functional independence, certain medications that a person might be on, nutrition, et cetera. There's also something called the Clinical Frailty Scale, which is more based on clinical gestalt. First, a physician might assess, and then you bring in some interprofessional team members like a physical therapist who can then sort of tell us, actually, no, they're not very good at this or that. 1 is considered very fit and robust, whereas 8 or 9 is considered very frail. 8 is reserved for people who are completely dependent for all activities of daily living, and 9 is for people who are terminally ill. And sometimes those are different. You know, someone who has maybe end-stage cancer could be a 9 because their life expectancy is less than 6 months, but they still might be more able, but they still wouldn't likely do well if they had another acute insult on top of that kind of end-stage cancer. And then the last one is the frail scale, which is a mnemonic. So F stands for fatigue, and there are specific criteria for defining fatigue. There's resistance, which is the ability to climb a flight of stairs, so achieving 4 METs. There's ambulation, which is the ability to walk a block, so another measure of 4 METs. And then illness, so you have to have more than 5 chronic conditions. And then L is for loss of weight, and that's more than 5% over a set period of time. And so if you get 0, you're robust. And if you have 1 to 2, you're intermediate. And then 3 and above are considered frail. So there are many, many more than just these. But there are some common threads in all of these, that you have comorbid conditions, physical weakness, and often nutritional compromise that leads to increased vulnerability. And beneath all of this is a lot of research that's done to understand kind of what physiologic processes are happening. And it's really believed to be kind of a vicious cycle. And you can enter this circle on any spot, but the most common areas to enter are just normal aging, where you're losing muscle mass just as part of growing older. I'm sorry, once you reach about your mid-30s, it's downhill. So do what you can. Also disease, which a lot of people accrue as they age. And then chronic undernutrition. So a lot of older people, for various reasons, don't eat enough. We get less hungry. People sometimes have food insecurity. All of that can kind of combine. And what that leads to is this loss of muscle mass, which we call sarcopenia. And that loss of muscle mass then translates into things like decreased strength and power, decreased VO2 max, and also a decrease in the resting metabolic rate. And when you have those decreases happening, things like walking speed are affected. And so that's something objective that's kind of easier to measure. But that lower walking speed makes a big difference in life. If you think about like crossing the street when they have like the flashing "don't walk" sign, you need to walk pretty quickly depending on the width of the street to get across. And a frail person often can't make it all the way. And so just that street crossing example is one way that walking speed that's slow can be a problem, but you can imagine other things. You know, low walking speed means if you have to pee, you might not get to the John in time. And that can be a huge issue for folks. And overall, when you are slower, you do less. And that means you expend less energy, and then that feeds back into the process. So you expend less energy, which means you eat less, and then you lose more muscle, and it just continues on. And these have all been borne out by different studies in frail people versus robust people in terms of defining the condition. But this isn't necessarily something that's easy to see when a person walks into your clinic on a day-to-day basis. And even though it's not easy to see, frailty is really common. So if we take just a general population of older adults, about 16%, so 1.5 out of 10 here, would be considered frail. And if we brought in the terms to just pre-frail, so those people that are kind of at risk, right on the edge, it's about 44%. So more than 1 out of or 4 out of 10 older adults are going to be considered frail, and that, or pre-frail or frail. And that's a big proportion. And we're not necessarily picking up on those things, again, because those diagnostic criteria are a little bit nebulous. But the thing that's an issue is that frailty causes worse outcomes. So in general, frailty increases the risk of procedural complications, falls, institutionalization, disability, and death, all bad things that most people want to avoid. And I wanted to look specifically at your population, so older adults with neurosurgical conditions. So that's what we're going to talk about next. So I did a literature review looking at frailty. So I just went to PubMed, searched frailty plus neurosurge plus outcomes, and I got 126 manuscripts that actually were about frailty. And they were all published in the past several years. So it's a very hot topic right now. There were 7 reviews, 113 retrospective studies, and 6 prospective studies. So between 2016 and 2023, they all came out, which is pretty impressive. There's a lot of work in this area. And just as a little bit of a side note here, frailty was assessed many different ways. So I've already talked about not anyone agreeing on like the gold standard. And that means that when you look at research, there's a lot of differences in how we actually measure frailty, which can make it tricky to compare different studies. But the most common measure of frailty, probably because it's the easiest to get, you can pull this right from electronic medical records and databases, and a lot of the studies were using the NISQIP database, was the 5-item modified frailty index. So they look at 5 particular conditions, and depending on how many of those you have, you're either frail or not. Others that were commonly used were the 11-item modified frailty index, so just a few more items there, 6 extra. The regular modified frailty index, the hospital frailty risk scale, the adult spinal deformity frailty index, which is a modification of the modified frailty index, and then the Johns Hopkins Adjusted Clinical Group's frailty defining scale, which is another sort of chart review based scale for frailty. And there are limitations to this data. So you already saw that it's primarily retrospective. And that obviously isn't ideal, but we can't really randomize someone to become frail versus not, and then compare outcomes, or randomize frail people versus not frail people to whether or not they get a neurosurgical condition. And so you just sort of have to take what you can get. And that's probably the best data we will have. They also focused very much on operative outcomes, but we know that not all of these people would necessarily have been candidates for the OR. And so we aren't necessarily looking at people who did versus didn't go to the OR and comparing those, but you can imagine that a lot of people might have been weeded out of these studies because they were such poor candidates for operative intervention that they weren't even admitted to, say, like a neurosurgical service. They didn't really fall into the database. Also, there were definitely different study designs that limit comparisons. So mostly retrospective, but different populations with each one, and different outcomes that they were measuring, different ways, again, of measuring frailty. So we're not necessarily comparing apples to apples here, but I will run through kind of a quick summary. This isn't a meta-analysis by any means of what we saw. And I wanted to start with what are typically elective procedures. So in non-oncologic spine surgeries, there were 39 studies, and they found that frailty increased length of stay. And you can imagine that someone who's weaker in general and doesn't do as well overall because of that is going to probably end up in the hospital longer. They're not going to bounce back as quickly. Number of ICU stays was also higher, and you can imagine that frailty making a person just more likely to tip over and become critically ill. There were more non-routine discharges, so more people ending up going someplace besides home without any services. So nursing facility, acute rehab, home with home health, assisted living, et cetera. There were also more people with complications in the frail group. And specific complications, including proximal junctional failure, I'm not a neurosurgeon, were also much more common in these non-oncologic spine surgeries. They also saw more return to the OR specifically for surgical site infections. And inpatient mortality, no matter what time period they measured it in, was higher. So just in general, inpatient mortality, 30-day mortality, 3-month mortality, 6-month mortality, it was all higher in the frail group, which is probably not surprising. They also saw a lot more dysphagia, which makes sense intuitively. If you're losing muscle mass, you're also losing muscle mass in your swallowing muscles, and so it all kind of goes together there. Also, along those lines, feeding tube placement was higher in folks who were frail. Overall, in the long term, a lower health-related quality of life, risk for poor functional recovery and pain relief, and subsequent cognitive impairment. And so you can see a lot of bad things were more common in the frail population. I will say there were a few studies, just a handful, about 3, where they didn't necessarily find worse outcomes with people who were frail. And that was primarily in the adult spinal deformities group. So people who were frail and underwent surgery for adult spinal deformities actually had some better outcomes when you looked at improvement in function, and the authors there theorized that they just had more to gain. So if you had, terrible kyphosis or what have you, and it was really limiting your daily activity, the surgery might give you an opportunity to get a lot better just because that deformity was so restrictive on your ability to function. Oncologic spine surgeries, so potentially semi-elective for some people, but not always. There were only 10 studies here. Frailty increased length of stay, non-routine discharge, complications, 30-day mortality, unplanned readmission, and reoperation for surgical site infection. So not necessarily surprising. Fewer studies, so fewer outcomes were measured overall. When they look at brain tumor resections, we see a similar pattern. So there are 25 studies here, and they saw that frailty, again, increased non-routine discharge, and so this is a theme. Post-operative delirium was higher, complications in general were higher, length of stay was higher, and you can imagine length of stay being higher for lots of reasons, but also I think if you are going to a nursing home, you guys have seen how long that takes. And so even if you were otherwise medically ready to leave, waiting for that bed in a facility can extend length of stay quite a bit. The ESL just generally saw poorer functional outcomes. There was higher mortality, and overall survival was shorter by about 4 months, which is pretty significant when someone's life expectancy might be measured in months. They also had higher 30 and 90-day readmissions and higher hospital costs. Meningioma resections, so maybe a little less critical than a brain tumor resection, but still important. There were 7 studies here. And again, similar themes: complications, length of stay, mortality, non-routine discharge, unplanned readmissions, morbidity, reoperation, hospital costs, all higher in the frail population. Pituitary tumor resections, again, very similar. 6 studies here, length of stay was higher, complications, unplanned readmissions, non-routine discharge, mortality, and costs. There was 1 negative study here. Frailty did not increase the risk for some very specific outcomes. So overall, and sinonasal specific quality of life measures weren't necessarily worse in frail populations. And also poor endocrine outcomes didn't seem to depend on frailty status. So, being pan-hypopid or something like that. And then complications and mortality weren't higher in this one particular study. There is fewer data when we look at neurovascular conditions, so unruptured intracranial aneurysm procedures. There were 3 studies here. They did see frailty increased complications, less likely to regain functional status or end up with poor functional status was more common. Hospital costs, length of stay. When the patient had an aneurysmal subarachnoid hemorrhage, there were 6 studies here, and they saw increased complications, length of stay, total costs, non-routine discharge, trach or G-tube, and poor functional outcomes, which again probably makes sense as you think about populations that you've taken care of. 2 negative studies here, so 2 out of the 6, both by this gentleman, or just one by this gentleman, McIntyre. He's all over the frailty data. So he found that bleed severity was more predictive of outcomes than frailty, although frailty was predictive in his study. So if you have a bad bleed, you're not going to do as well, and frailty may not be as influential if it's a really bad bleed. Eng in 2023 also found that frailty was specifically not associated with a risk of acute kidney injury, for what it's worth. So that was a very narrow outcome they were looking at. Traumatic subdural or intracranial hemorrhage, there were 4 studies here. And again, kind of the same story, more complications, more non-routine discharges, more unplanned return to the ICU and to the OR, more ventilator days, and ICU length of stay was longer, length of stay in general longer, and 30-day mortality higher. Chronic subdurals with or without evacuation, 3 studies there, more dependency, so poor functional outcomes overall. There was 1 negative study here, this McIntyre guy. He found that comorbid conditions were more predictive of outcomes. And so thinking about frailty and having comorbid conditions measured in there, it sounds like the other things we think about with frailty weren't any additionally predictive. Traumatic spinal cord injuries. So, again, something that you don't necessarily plan on happening. And so these are people who are probably going to the OR less optimized. 3 studies here, again, higher complications, length of stay, in-hospital mortality, and non-home discharge. A few other conditions that I found papers on, vestibular schwannoma resection, again, pretty similar outcomes here. Epilepsy surgery, again, similar outcomes, and then angiogram-negative subarachnoid hemorrhage, again, more mortality, non-routine discharges. So pretty consistent across the board. Frailty is bad. And I think this would be a very depressing morning if I told you it's just bad and your patients are going to do worse, and I didn't try to tell you some of the things you can do. So that's what we'll talk about next. And when we're talking about mitigating frailty, it's not necessarily kind of everyone is the same. So it's a little bit of an apples to oranges situation depending on whether or not this person is undergoing a planned procedure or not a planned procedure. And so when a person is undergoing a planned procedure, you can kind of take the offensive position and try to build that person up before they go to the operating room. And we'll talk a little bit about that. That was covered extensively by Dr. Eastman in May, so I won't go into too much detail. When a person is frail and you don't have a choice, they need to go to the OR or they will die or have a very bad outcome, you then are more having to play defense and you're doing your best to sort of fend off the bad things that may happen regardless. So being on the offensive side for planned procedures, it's really this concept of doing the usual perioperative cardiac workup that everyone gets that says, you know, they can achieve 4 METs and they're not at an increased risk, you know, perioperative risk of cardiac outcomes, et cetera, but also then adding in this comprehensive geriatric assessment. And so this is what Dr. Eastman talked about. And that specifically includes several items. One is a cognitive assessment, so understanding whether the person has any cognitive impairment or not. Assessment of mood, so looking for things like depression, which can affect outcomes and a person's ability to care for themselves after a procedure. Frailty is in there, so using a frailty index, I believe that she uses the Frail scale. Functional status, so how independent is this person? Nutritional status, and she uses a standardized questionnaire there to assess nutrition. Pulmonary status, there's lots of undiagnosed lung disease out there, and so knowing that ahead of time can help prevent pulmonary complications. And then assessing decisional capacity, because if a person is not decisional, maybe they're still appropriate for the OR, but you want to be sure that someone who is decisional is helping make that decision. So if cognition is impaired in this preoperative setting where you have some time, you can do some aggressive delirium precautions. You can really try to optimize that person prior to surgery and look for reversible causes for cognitive impairment. So, you know, check the B12, check the TSH, correct some of those things that we know can affect cognition and can be fixed. I wish I found more of these reversible cases. It's not that common, but hey, if vitamins make the difference, hooray for you. And it probably won't hurt. Mood, you know, if a person is depressed, we can start treatment. We can start an antidepressant, and even within 2 weeks, we often do see some benefit. So if you've got that 2-week lead time, it might be worth it. Sometimes we'll even do a bridge of methylphenidate to kind of give someone a little bit of extra oomph leading up to a surgery or in a recovery period if their depression is pretty pronounced and we're still waiting on that SSRI or SNRI or whatever to have its effect. When it comes to frailty, functional status, and nutritional status, when we find someone is frail, they have functional impairments, which likely means they're also frail, or they have poor nutritional status, which probably means they're pre-frail. We really try to emphasize that prehab idea. Now, you can't ask Medicare to cover prehab, but if a person has a deficit in strength or balance or whatever, therapy services are covered. And so this is where we get them into PT and OT, and we really have them working on exercises to build up some of their strength in advance of the surgery that we know is going to knock them down a little bit. And then try to optimize nutrition. We have wonderful nutritionists here. Sometimes it's as simple as just saying, like, eat some you know, extra protein. Sometimes you might need some boost, and sometimes they really need that kind of nutritional assessment and maybe some community resources to help them get additional access to food if they are food insecure. When it comes to pulmonary status, there's lots of things we can do for folks. Obviously, if someone is a current smoker, we would advise that they stop because that does improve outcomes as long as you have a little lead time there. But if we're not dealing with someone who's currently smoking, there are evidence-based treatments that can be helpful in terms of like long-acting beta agonists, inhaled corticosteroids, et cetera. So there are things we can do here to help their perioperative pulmonary morbidity. And then decisional capacity, obviously, we want to activate a power of attorney if that's needed. And for those of you who aren't from Wisconsin, our talk about activating a POA probably is goofy. That's okay. Basically, if someone lacks capacity in one area, we activate the document, but they're still allowed to participate to the extent that they're able in decisions, but we want that surrogate involved as kind of a backup. So what do you do when you are dealing with someone where you don't have that luxury of time. I think this is most of the people I see because I only practice in the hospital. So I never get to see someone who's doing great. They're always in for a reason. So maybe I have some sampling error there. Dr. Eastman is the optimistic geriatrician. I'm the pessimist. But the two things that you can try to do in this population is identify frailty and then adjust the approach based on the presence or absence. And you'll probably find a lot because I think a lot of the things that get a person acutely hospitalized for a neurosurgical emergency tend to mean that they are on the frail side, right? Like they fell and they got their subarachnoid, or they sat down too hard on the toilet and they got a head bleed. There are things that happen that bring people to you that are probably pretty obviously associated with frailty. So when it comes to identifying frailty, my personal favorite tool is the clinical frailty scale because it's very visual and it's really kind of just clinical behaviors that you can look at or symptoms and signs. And so this is what the scale looks like. I love that there's little illustrations. Number one, so this is a person who's considered robust. They're exercising regularly. Fabulous. They're going to probably do just fine. Then there are the people in the extremes, the 8s and the 9s, and these are people who are essentially hospice eligible. And those are probably patients where you're going to be like, no way, right? Like they're going to probably be pretty obvious from the get-go. But there's a lot of people in the middle here, and really the cutoff point is right around that 4. So these are people who are chronically ill, and they're independent, but they're struggling. And so if you have a score of 4 or more, that's where we start to see worse outcomes. And so these are kind of the people to look out for. And I don't imagine that in your days, you're going to pull out the clinical frailty scale and start looking for this because you are very busy, and I recognize that. These folks are the ones you want to look out for, and you are definitely welcome. You know, if there is a little bit of time to consult our team, ACE, we're happy to kind of do a frailty assessment for you. If there isn't time for that, don't underestimate clinical gestalt. So when it comes to frailty tools, we have all of these different metrics, all of these different ways you can do it, but it turns out that just knowing a patient and looking at them can be pretty good. So primary care physician clinical judgment performed as accurately as standardized frailty screening tools in a rigorous study. So if you're not sure, call the PCP and be like, do you think this person's frail? And if they say yes, they probably are. So that's the upshot there. I think sometimes you know it when you see it. If you've got a bad feeling, it might not be as sensitive, but it's pretty darn good. So if you're in this situation, our ACE team is happy to help. Just a little plug for my people. We can do a comprehensive geriatric evaluation and try to get you the information you need. And then the next piece is really adjusting your approach based on the presence or absence of frailty. And so thinking about frailty is kind of a spectrum. You've got your people on the top who are robust, they're doing great. The people in the middle who are kind of pre-frail, they're iffy, things could go either way. And then you've got severely frail folks. For those robust people, the best we can do is some pretty kind of basic stuff in the post-op setting or the hospital setting that isn't going to sound really exciting. So this is probably why I don't have any things to disclose. There's no drug company that's going to sponsor these things, like encouraging out-of-bed activity as soon as possible. But that's really important. And I recognize that that's easy for me to say and very hard to do because there are a lot of reasons that a neurosurgical patient might be on bed rest. And just the reality of things like staffing. If a person is on the weaker side and need assistance for ambulation, that's going to be tough to get the staff assembled to actually do it. So again, easy to say, hard to do, but as much as you can, if there's no indication for bed rest, try not to have it ordered and really write in your orders, like out of bed to a chair 3 times a day, 4 meals. They're really great on the surgical floors, truly, in doing this compared to my medicine floors. So I'm a little envious of the nursing staff in the surgery units. Involve PT and OT like as soon as you can. So the reason this is helpful is that they are going to figure out what the best way to mobilize a person is. They really get a good history on prior level of function as well. And so that can give you an indication of how things were going before they came in. And they're doing more than just talking to the person. So I get to breeze in even as a geriatrician and I ask a lot of questions, but I'm not making a person do a lot of things physically for me, but when OT and PT get in there and they're like, okay, I want you to get up, walk here, follow this multi-step instruction to do this thing for me, they get a lot of observation in terms of how well that person is processing, thinking, et cetera. And so oftentimes, even before nursing staff will pick up on some cognitive issues, OT and PT will. Push oral intake and hydration, we starve our patients in the hospital. So roughly a third of times that people were NPO, it was for nothing. And we do that because we know that if they're not NPO and then we can't do a procedure, we're going to regret it. But as soon as you find out that they can't eat, be sure that diet is ordered. I think nursing is great about like hounding you with the pages, like, please, can we feed this patient since such and such isn't happening? But do think about that and think about hydration as well. We do see a correlation between becoming dried out, so hypernatremic, and confusion. Promote sleep. Again, this is easy to say, hard to do. No one sleeps well in the hospital, and I don't imagine that anyone ever will. The beds aren't uncomfortable, and then we bug them a lot. And obviously, neuro checks are important. And I'm not going to say like you don't need that Q1 hour neuro check when the person first comes in, because that's not standard of care and would be probably malpractice. But as soon as they're stable and you can go down to Q4 hours or Q shift, do that. And ask that nursing really cluster cares. So if they're going to be in checking their neuro status every, however many hours, that's also the time that they can give medications, that they can do their nursing assessment. What drives me nuts is when, we get vitals at like 2 a.m. and then at 3 a.m. we come and do the nursing assessment. And then at 4 a.m. we come and give a medication. Like, let's just do it all at once so that we're not waking that person up all those separate times. Also keep the person busy and engaged in the daytime. If you really tire them out in the day, they will sleep even if we're bugging them a lot at night. And so that means like figuring out what they like and having some things to do, encouraging family to come visit and just talk to them, trying to have that kind of support so that the person isn't dozing off all day. Address hearing loss and low vision. You can actually get little sound amplifiers. They can't be called hearing aids because they were developed before hearing aids went over the counter, but you can actually order those from Central Supply, just have the nursing staff do so. And we have reading glasses and magnifiers for people in Central Supply too. So we know that correcting those sensory impairments can make a big difference for people. And then avoid potentially inappropriate medications. No opioids that are excessive. The sort of standard 5 to 15 of oxycodone is probably too much. Do 2.5 to 5 for my people. If you look at them and you're like, oof, I don't know, they need less opioid unless they're on it chronically. Don't use anticholinergics, so no diphenhydramine if you can help it. Benzodiazepines do avoid, especially if they're new. If someone's on them chronically, don't stop them because withdrawal is also crummy. And avoid the Z drugs, zolpidem, mesazolpicone, et cetera. So this stuff doesn't sound exciting, but this is essentially something called the Hospital Elder Life Program, or the HELP program, which has been found to reduce delirium by 1/3. And we know that it also decreases things like falls, may reduce length of stay, and non-routine discharge. And so this is a great program that you can do basically just by being kind to patients and letting them sleep, eat, and being a little bit stingy with their opioids. When it comes to the pre-frail group, we're going to do all the same stuff. But the other things to think about would be ACE consultation. We are happy to see the person and do what we can. We sometimes feel like the activities director on a cruise. We're like, let's bring in some puzzles, let's bring in playing cards, but kind of things that occupy a person's mind. Cat videos. I sometimes am like, I went to medical school and now I'm saying load YouTube and have someone watch cat videos, but it is what it is. Disclose additional risks of pre-frail status if you're consenting someone. So I think the other piece is really being upfront about communication. And as you guys were talking in your M&M conference, it sounds like that's something that you definitely think about and I think is worth kind of understanding. Being realistic about outcomes, knowing like this person is at higher risk for these bad things, and making sure the family hears that can be important. And making sure that a non-routine discharge going to a nursing home is acceptable to a patient. If they say no, you might not really want to push them to go for an aggressive intervention. When it comes to the severely frail people, it gets tougher. So obviously we're going to still do all those same things that we do for other folks. But we're also going to have to think about their sort of global picture as geriatric patients, and something called serious illness communication. So in the palliative care world, they used to talk about advanced care planning, like think ahead and plan for what you want. And what we've realized is that advanced care planning doesn't actually improve a lot of outcomes because people have a really hard time imagining what they will be like in the future and what they might want. It just doesn't work very well. So serious illness communication is more the new idea, which is when something bad happens, talk very frankly about what's important right now. And so these are the geriatrics M's. It's part of the Hartford Foundation's age-friendly health systems. And so it's 4 things to think about with older adults. And these are all things that our ACE team can help with, palliative care can help with. But M is for medications. So are the home medications appropriate? Is there anything in there we can nix that might help them do better? And are the current medications causing any problems? So if we're seeing side effects, constipation, if we're seeing stomach upset that's making them not eat well, can we get rid of those to improve their outcomes? Mentation, so what is their cognitive baseline? This is hugely important because if a person is impaired at baseline, and they've had, say, a brain injury of some sort, we know they're going to do worse. And so knowing that ahead of time can be important when it comes to thinking about their potential outcomes. Are they delirious now? What can we do about that? Are there some obvious delirium triggers that we can intervene upon? Is depression present? And if so, is that going to affect the person's ability to do well? What is their prognosis based on the insult, keeping in mind all of this baseline cognitive stuff going on? And then mobility, how is the patient mobilizing right now? What are they at baseline? And if someone, say, has new hemiparesis and they were already needing help with mobility, what is the likely outcome, even with the best case scenario? And then finally, and I think this is the most important part, it's what matters. So that's our other M. What is their current quality of life? Is it acceptable to the person? If that quality of life is worse based on the likeliest functional outcome, is proceeding with aggressive care really within their wishes? Does it align with what matters most? And so that's where the serious illness communication thing comes in. And I don't expect you to become experts in serious illness communication. I am not myself. And I do rely on my palliative care colleagues a lot. But the elements are, number one, just figuring out what the patient and the family understand. And truly, whenever I see a patient, my first question is, what's your understanding of why you're here? And you would be shocked how many people do not know. They actually did a study of this, and 47% of people in the hospital either didn't know why they were hospitalized or had the wrong reason for why they were in the hospital, which is about half, and that is shocking. And when they were wrong, a good portion had an entirely different organ system that they thought was sick. So, they're in with heart failure and they're like, I think it's my lungs. And so there's lots of problems here with just people understanding what's going on. So if you can do nothing else, just making sure that you're on the same page as far as what the medical condition is the first step. The next step is to share information according to preferences. And so, this is tough, but you can ask, how much do you want to know? Do you want to know about prognosis? Most people do. Respond empathetically. It's crummy. You're seeing people in bad situations all the time, and just letting them know that you can't imagine what they're going through, I think is a good response. Explore the patient's goals and values and priorities. So that's that matters most piece. What is important to them? And then make medical recommendations about the next steps. Oftentimes, patients are sitting there and we're sort of waiting for them to tell us what they want to do. And they're like, I don't know. What do you think, doc? And that drives me nuts. But when you have that opportunity, you can chime in with a frank discussion about what you think is the right thing to do. And I know we've just got a minute, so I'll zoom through here. The best worst case scenario is the framework that I really like. Gretchen Schwarzy, who you guys probably know from vascular surgery, really has done a lot of study in this area. And so it's not necessarily talking about like, you have X% risk of this particular surgical complication. It's saying we have 2 options, surgery or supportive care. Best case scenario, this is what it looks like. Worst case scenario, this is what surgery looks like. And then going to supportive care. And then drawing out for them, I think you're most likely to have this outcome. And then is that acceptable to you? And really framing the outcomes based on what the person says is important to them. It results in improved quality of communication. So it's an effective method for kind of informing your patients. And I think that's the best we can do for severely frail patients. They still might want to go gung-ho and do all of the things, but if you can at least have a conversation in advance, so that they aren't blindsided when bad things happen. I think that's what we can do for them. So summary here, and then I'll let you run to the OR. Frailty is a state of decreased physiologic reserve that increases the risk for poor outcomes. I've probably banged that into your head quite a bit at the end of these 45 minutes. Despite significant heterogeneity in studies in general, frailty leads to longer length of stay, complications, more morbidity and mortality, and worsened clinical outcomes in neurosurgical patients. And attention to activity, nutrition, sleep, potentially inappropriate medications, sensory impairment, and frank discussions about prognosis help address the risks of caring for frail patients. And that is all I have. I'm happy to take questions, but I know you guys have lots of work to do. So thank you for your attention. It was great to see you, and I'm sure we will have lots of shared patients in the future. Thanks again.
You made a great case that frailty is more important than age. However, is there an age cutoff for this? Because I see frail 30, 25.
Yeah, so there's technically no age cutoff. So certainly the older you get, the more likely you are to be frail, but you can see these young people who are incredibly frail. And I work half time at the VA, and so I can tell you there's a lot of veterans out there who are in their 50s or 40s, and you're like, holy cow, you look like you're in your 70s. And it's truly the frailty itself and not the age that matters. So great point. You do see those people who are just sometimes so chronically ill at a young age, and maybe that's because of, chronic conditions, tough living. There's a lot of reasons.
Thank you very much.
All right, thank you guys. Have a great day. Enjoy your Wednesday.